our improvised broadcast for spine surgery this week. Unfortunately, our broadcaster, Diego, has had a family emergencies and has had to leave and go back to New Jersey. So we have Chet and Sunny who are running our broadcast today. It's Thursday, January 6, 2022. It's a new year. We actually did 2 surgeries yesterday, but we couldn't broadcast them, unfortunately, because we didn't have the ability to. But we're going back to broadcasting now. It's going to look a little different for those of you who follow us normally, but we'll get it back soon. At least we're broadcasting. Okay, Dr. Duke here. Just relax, all right? Are you comfortable? Yes? All right. I'm going to give you some numbing medicine. You'll feel a little pinch and a little burn. That's just the medicine going in. That's my hand touching your back, okay? I want you to get comfortable. If you feel any discomfort, say ouch, and I'll give you more medicine, all right? But don't move around, okay? What'd she say? Yep. More topical? Don't worry, you'll be all right. Yeah, this is probably one of the worst parts of the surgery right now when I give you the local, the topical. All right, you're doing fine. Okay, we're going to get started. If you have pain, just say ouch and tell me where it is, your back or your leg, okay? All right. Num num. Try not to move around, just say ouch. Okay, so our patient has 2 herniated discs. Just, do we have ketamine? How do you feel about it in the beginning? To give a little dissociative anesthesia. That way, I mean, it sort of helps the patient's comfort level. Local? Yeah. You see why? Are you okay? Ma'am? So I'll be talking to you as well as my team, as well as our broadcast team. So the operative team, the broadcast team, and you. Mostly to them, not so much to you. But if you're having discomfort, like I said, let me know. The Duke laser disc repair is performed on cervical, thoracic, and lumbar parts of the spine. And right now we're treating 2 disc herniations in the lumbar spine, L3-4 and L4-5. You're fine, just relax. Everything's okay. That's just more numbing medicine going in. Shot. Our patient comes to us from Jacksonville, Florida. Is that correct? All right. You're fine. Everything is okay. Shot. And she was involved in an accident, and as a result of that accident, she now has horrible pain in her back and left leg, which is why we're treating the left side of her lower back, so we can treat the nerve root that's getting irritated in the foramen at L3-4 and L4-5. She's really got far lateral shot disc herniations, one at L3-4 and one at L4-5. They were, I think, missed by her radiologist that read the study, if I'm not mistaken. I'm going off memory here. So I'm passing through the foramen on the left side. Beautiful. She doing good? All right, we're almost to the disc shot. And I'm really just caught up on the superior articular process. So there's a way to get around it, and that is essentially to rotate the needle and go more lateral. Shot, nice and slow. Let's get an AP. So we're in the neural foramen. That's that open space. Jordan will show you. Where's our base? Our fluoro base. Can you go show them the neural foramen, Flynn? Use the mouse. All right. So, nope, that's not it. We need to go back to a lateral. Just hold off for a second. I want to reposition my needle. I'm too medial. Let's go back to a lateral. Just hold on, Flynn. I'm sorry. I got you going too soon. All right. So I want to be a little more lateral. I think I want to have even my entry point maybe okay, but let me see here. Shot. I'm right up against the facets. Shot. All right, let's get an AP. I need to be a little more lateral from the last AP. Now we're starting with L4-5. You can see the L5 vertebral body below. You can see the L5-S1 disc space. So the first disc I'm going to access is L4-5. That's much better. Let's go back to a lateral. You can see the pedicle of L4, the pedicle of L5. The tip of the needle is just sort of between the two pedicles, aiming for that L4-5 disc. All right, so we want to be right where we are, basically. Her herniation is in the foramen. Will you show them the tip of the needle now, Flynn? The tip of the needle is there. Just point to the tip of the needle, yes, and that's in the foramen. Show them the foramen. It's that whole white area. Yeah, that's the foramen. And then the disc herniation is right where his pointer is right now. So that's where the herniation is. And it's coming into the foramen. All right. Looking good. She responsive? So right now I'm up against the herniation. Let's just pull our fluoro down a little bit, and I want to see the sacrum. I want to be 100% sure we're at the right disc, which is L4-5. Yeah, take your time. All right. Luis, you agree that is the L4-5 disc? I see the sacrum. Show them the sacrum. The sacrum looks like an ice cream cone. Yep. All right, no, down a little bit. Yep, that whole bone there. Go down to the left. There you go. That whole bone is the sacrum. There it is, that whole thing. It looks like an ice cream cone. Then the first disc above that is that's the L5 bone where the arrow is. Now come down to the disc between them. Yeah, that's the L5-S1 disc. Perfect. We are not treating L5-S1. There's nothing wrong with L5-S1. We're treating L4-5 and L3-4. So let's bring the fluoro back north. We know that the needle is at L4-5, so we're going to access this disc first, and then we're going to go to the one above at L3-4. So let's get the pedicles lined up. So I am perfect. So we're in the bottom of the foramen. You can actually see the herniated disc right by the needle tip. All right. So we're into the first disc. Okay. And now I'm going to do the second disc repair at L3-4, which needs to be done as well. Everybody agree L3-4, L4-5, correct? So I'm going to make a 7mm incision. 7mm is about ½ an inch. So the whole surgery will be done through a ½ inch incision. There's no scar tissue. There's no muscle damage. There's no fusion. There's no hospitalization either. She okay? Yeah. So, great. I appreciate that. It's really nice for the patient to use that. We've lost 1 drop of blood, by the way. Do you like using ketamine?
Yeah, I used it
Yeah.
yesterday.
Yeah. Oh, you did? Okay. You just hadn't given her any.
I gave her.
Now you have, but when we started, you didn't, right?
Yeah.
Yeah. It really helps for some reason. It's incredible. I think Santiago is the one that taught me about that, you know, using ketamine at the beginning just to make patients more comfortable while we gain access. All right, so same thing. I'm going to go, Sean, to L3-4 through the foramen. shot? All right. Let's get an AP, see where we are. Before I go any further in the frame, and I like to get an AP view, just to make sure I'm in the right spot. And you want to be at about this point just lateral to the facet joint. Yeah, so we're just lateral to the facet. I could be a little bit more medial. So I'm going to redirect to be a little bit more medial. And let's get another lateral view. So we're almost done placing the needles. I'll need her awake and responsive soon. Shot. I can actually feel the herniation right there. So I can feel resistance with my fingertips. And that is the herniation at L3-4. You can actually see it on the x-ray. Now, normally you cannot see herniations on the x-ray. But we have a really good machine, like top of the line. Semen. All right, now we need her a little more awake, and we'll go ahead and do our discogram. So our patient here has two herniated discs, one at L3-4 and one at L4-5, and that's what I'm drawing on her back right now. She's got an annular tear in both on the left side, and the nuclear material from the center has literally pushed out through the tear, creating what's called a herniation. And her herniations are a bit unique in that we call them foraminal herniations because they're in the foramen. Now, most herniations are in the spinal canal, more centralized and paracentral, but hers are really lateral in the foramen. And I think that's why the radiologist didn't really see them or wasn't as impressed, because the foraminal herniations are to the side. They're not common. They're about 5% of lumbar disc herniations. And most radiologists miss them, you know, because they're not trained to see them. But it takes an expert in the spine to really see them. They were very easy for us to see. And they were pushing on her nerve roots, her left L3 and L4 nerve roots. So lateral foraminal disc herniations will hit the exiting roots. Just let me know when she's awake, okay? She's doing okay? Yeah, take your time. So what we're going to do now, folks, for those of you who have never seen this done, is we want to confirm that her pain is indeed coming from, her back pain is indeed coming from L3-4 and L4-5 discs. I believe it is, based on where she showed me her pain was yesterday or 2 days ago in clinic. And I looked at the MRI, and indeed there's two herniations, L3-4 and L4-5. She's ventilating good? Yeah, no problem. We'll wait a few minutes. So the discogram, which we're about to do, is really a diagnostic test, and it's used for several things. A lot of people don't understand what discography is for. It's used, number one, to see if that disc that's clearly abnormal on the MRI is indeed the source of the patient's back pain. And it can be done in the thoracic and the neck as well. So let's just say if it's the source of their spine pain. The second reason you do a discogram is you want to see if there's a tear, which we already know there's a tear from the MRI. And you want to see if that tear is healed or if it's still active. And typically in a patient with back pain that comes from a herniated disc, the pain is coming from the tear in the disc, in the wall of the disc, in the back. Now, tears in the front of the disc or side of the disc don't cause pain. Are you comfy? You have back pain every day, right? All right. All right, we're almost ready to put you to sleep for good, okay? Are you comfortable? Are you comfortable? All right, good. All right, how bad is that on a scale of 1 to 10? How bad is that? 10? Is that where you typically get back pain? All right, good news. We found one of your bad discs, okay? I'm so sorry, but that's good news. I know you're not happy with me right now, but you will be happy later. Okay, when we fix it. Now take a look at that disc. Show them the disc with the arrow. Look at the tear, the giant tear in the back of the disc, okay? All that black dye right there should not be there. Show them the center of the disc where the normal dye is released. That's right, the dye should all be there and not extravasating out the back like it is. Okay, get ready, doctor. We're going to put her to sleep in just a moment. Are you better now? All right. How bad is that on a scale of 1 to 10? 12? All right, we can put her to sleep. So, is that where you typically get pain? All right, you get to go to sleep now. Count for me out loud, 1 to 100. Good job. Keep counting. Keep counting. Show them the tear at L4-5. So we did a discogram at both discs. You can see there's massive tears in the back of the disc. The dye is leaking out through those tears. Those tears are the source of her back pain. We're going to go in there and clean the tears with the laser. It's part of the Duke laser disc repair procedure. When we clean those tears with the laser, we call it a debridement. Once that's done, her back pain will go away from the discs. Now, if she has other causes of back pain, like her tailbone's fractured, obviously we're not treating a fractured tailbone here, we're just treating a disc problem. But 95% of the time when you have disc pain and you fix the tear in the back of the disc, the pain goes away permanently. You're okay, just relax. You're doing great, don't move. So she's going to sleep now. Yeah, and I'm telling my audience, once she goes to sleep, we're going to do Propofol Sedation. She doesn't have a tube in her throat. She's not under general anesthesia. We are at a surgery center at the Duke Spine Institute. We are not at a hospital. So none of our patients go to the hospital. There's no reason to go to the hospital for the surgery. It's minimally invasive. The whole thing's done with a 7mm incision. Right now I'm going to bring the dilator down the guide wire. You can see it on x-ray. Switch to x-ray. Good. You can see the tip. It looks like a pencil. It's not really a pencil. It's called a dilator. What it does is instead of damaging the muscles and soft tissues like fascia, it actually pushes them apart, spreads them. Okay? Spreads them, and when we're done, the tissues come back together, and there's no damage. Now, opposed to open surgery, where the surgeons cut this big cut on the skin, peel the muscles off the spine, they destroy the muscle, and then they, when they're done, they also have to take bone out. You see the bone that I'm passing there? We're going around that bone, not through it. Most spine surgeons go through the bone, and to do that, they have to literally drill it away. So we're not drilling any bone away. We're going around it to the side. Sean? This technique of going around the bone and through the neural foramen, it's called transforaminal. This was designed and developed by Dr. Parvis Camden. He was the first one to do it. He was an orthopedic surgeon at Pittsburgh. And this area that we're in is called Camden's Triangle, or safe zone. Yeah. Shot. So we're passing through the tear, and I can tell you it's a big tear. You can see it on the discogram just how big it is. It's huge. I mean, that went in so easy. When the dilator goes into the tear easily, it means it's a pretty fresh tear. Now, when was her accident? Shot. Shot. So I'm advancing the tube. The dilator. That's what we're going to do this surgery using a dilator. I mean a tube. A tubular retractor is called. I can see it. It's just entering the tear in the disc right now. I'm also watching the tip of my dilator to make sure it's not going in any further. I don't want that tip of the dilator going in any further. If it goes a little further, it's okay, but you don't want it going past the front of the disc. Shot? Let's see where we are. All right, so I need to go a little further. Now I can tell you there's a lot of pressure in the disc. It's literally pushing my tools out, back out. Shot? It doesn't want us there. So what does it mean when there's a lot of pressure? What it means is there's a lot of inflammation, because inflammation causes edema and pressure. So what I'm dealing with is a lot of pressure inside the disc from inflammation. That inflammation comes from the annular tear. It's a huge annular tear. It's relatively new, and there's tremendous amount of swelling inside the disc. And that's creating pressure on the tear and not allowing the tear to heal. So there's more inflammation because the tear wants to heal. Again, this was all pioneered, and a lot of this information was discovered here at Duke Spine Institute through endoscopic spine surgery. Learning. So now we're going in with the endoscope, down the tube, and inside here we're going to see we're inside the herniated disc, the damaged disc. There's a little bit of inflammatory tissue right there. And I'm going to start by using my grabber, the pituitary. Can you see this? Sonny? Chet?
Yes. Got
So
a question, Doc.
We have a question?
Yes.
All right. All right, let's do it. Why not? Let's go full bore.
Okay. First question. How strong is it ACDF with dual vertical peak cage after surgery?
All right, so let me hear that again. That was pretty good. How strong is ACDF?
With dual vertical after surgery.
With dual, what is it, dual what?
Dual vertical peak cage after surgery.
All right, how strong is an ACDF with a peak cage after surgery? Honestly, it's hard for me to visualize what you're asking me, but it sounds like you're asking a single level ACDF, I imagine, as opposed to a 2 or 3 level, because it makes a difference. And then a peak cage, and I don't know if there's a metal plate or not. And if there is a metal plate, are you telling me the screws are properly sized so they're big and fat and they go as deep as possible? If that's the case, it's a very strong construct, but it depends on the patient's bone quality. So if the patient has poor bone quality, soft bone, then it's not going to be as strong as it could be in somebody with hard bone. I don't know if I'm answering the question properly for you, but that's my interpretation of what you're asking. Yeah. October 28th, all right, last year. So this patient had an accident where she got hurt, and she has a herniated disc as a result of that accident. Look at all the swollen nucleus here. It's very edematous. This does look very consistent with an accident that's about 1 year and 3 months, 4 months old. So her tears are consistent with that accident as well. So everything about what I'm seeing here endoscopically, the way the tissue responds to the laser, is very consistent with a recent injury that's about 1 year, 1.5 years old. By the way, I just saw the patient we did yesterday. We did 2 laser surgeries yesterday. One patient was from Boston. The other patient was from Pennsylvania. Was he Pennsylvania? I thought he was, but he says he works in an oil rig, oil industry. So, no, the tall one, the lumbar. So is there oil stuff up there? I guess a refinery. He works in a refinery. Maybe there's a refinery up there. Anyway, he said his back pain is 100% gone. His leg pain is 100% gone. He's very happy. But he had to catch an early flight, so I saw him in clinic, and he's already gone. Less than 24 hours after his Duke laser disc repair. That was our second patient. So he had already had a fusion at L5-S1 done by some other doctor. He was very unhappy. He had adjacent segment disease at L3-4, L4-5. We did basically L3-4, L4-5 Duke laser disc repair. And his pain is 100% gone. He was smiling and happy. So we didn't get to do a video because we don't have a videographer. But we're trying to make do the best we can. We're a small company. We don't have gazillions of dollars to waste. We have to be frugal. And we have only one videographer. And he was amazing. But unfortunately, he had to leave. That was Diego. Anyway, we'll find somebody else. In the meantime, we'll do the best we can. I'm getting bubbles. Maybe it's... Is the fluids good? So what I can tell you about this is a massive tear. Literally the tear goes from side to side, and all this blue stuff that we've stained is nucleus pulposus. It's basically the jelly from the center of the disc that is now degenerating. So why is it degenerating? It's degenerating because of inflammation. Inflammation tends to destroy things. That's what inflammation is. It's a destructive process. It's carried out by your own body, and it's designed to attack indiscriminately foreign bodies. So what's considered a foreign body? Well, let's say you get a nail stuck in your foot, and the nail has bacteria. It's going to put bacteria from the nail into your body. So the inflammatory system attacks the bacteria. It attacks the pieces of rust or metal. It attacks anything like a piece of wood, a pimple, anything that shouldn't be there, your inflammatory system attacks. And it's not specific like the immune system. So you have two systems of attacking, the inflammatory and the immune. And what causes most pain in the human body is inflammation or inflammatory system attacking things, okay? So with a herniated disc, what's being attacked is the jelly from the center of the disc. See the tear? That jelly that's being attacked by your inflammatory system inside the disc herniation is not normally seen by the body because it hides away in the middle of the disc during embryology, during development in utero. So before you become an adult or a child, you're a developing fetus, and the nucleus pulposus was the notochord. The notochord is very important in orchestrating the development of the primary germ tissues like the endoderm, mesoderm, and ectoderm in a developing fetus. And then the notochord disappears and it becomes the nucleus pulposus. So it's just ironic how something so important to life and the development of life becomes a cushion between the bones in your spine. But anyway, most people ignore that cushion. They've ignored it for forever in medicine. And there's only been a few scientists worldwide over time that have started to understand the importance of that nuclear jelly, that notochord remnant that's located in the middle of the disc, called the nucleus pulposus. Okay? And those scientists started to recognize its role in pain and inflammation. It's a very inflammatory material. It causes inflammation. I did not discover that. That was discovered by scientists who took nuclear pulposus material and put it on living membranes and tissues in vitro experiments, in the lab, and they found that it promoted inflammation massively. So we know that the nucleus pulposus material, the jelly in the center of the disc, is very inflammatory. The good news is that normally the nucleus pulposus doesn't have any access to the inflammatory system because the center of the disc has no blood supply. And the inflammatory system travels via, blood supply. So if there's no blood supply to a part of your body, you can't get inflammation there. So how does it work then? Well, what happens is you get a full thickness annular tear from inside the disc to the outside. It allows the nucleus pulposus to leave the center of the disc, travel through the tear, and come out on the outside of the disc of the tear. And then when it gets to the outside of the tear, that's where all the blood vessels are that supply nutrients to the disc. That's where the pain fibers are. So immediately inflammation will start. Now, most people with a herniated disc, that inflammation dies out within a few days. And you don't even realize there's inflammation going on, and your disc heals. But in people who keep re-injuring their disc over and over again, they can keep getting pain from that inflammation because it never stops. See this tear right here? See the blue? The blue is the nuclear material stuck inside the tear. And the body is attacking that with inflammation. And that attacking inflammation causes back pain. If it happens in your neck, it causes neck pain. Laser. You got to pay attention. So basically, it's the response of the body to the nuclear material stuck inside the annular fibers of the tear that causes the back pain, neck pain or thoracic pain.
Got a question, Doc.
Okay. So go ahead, when you do the question, say who it's from, on what platform, and go ahead and say the question. So, for example, you would say, I got a question from John on Facebook, and he asks or she asks, whatever.
Okay, got a question from YouTube. Graham, how does the laser remove the herniated material?
So the question from Grant on YouTube, first of all, thank you for asking and being here and watching. So this laser, see the blue thing I'm shaking around at 12 o'clock? That's the laser fiber. There's a little bit of glass. It's really a glass tube. It's covered with blue plastic. And it transmits energy, very powerful energy, very focused energy, right through that little glass tube to the end of the tube. And it comes out about 0.5 millimeter from the end of the tube. So anything that I want the laser to interact with, the laser energy, I have to almost touch. So it doesn't just shoot around the room. Okay, a lot of people think it does, but it really doesn't. So anyway, I have to kind of touch the tissue with the laser, with the tip of the glass tube, and the laser energy comes out of the tip. And what laser does is so powerful, it just basically blasts the tissue apart into little pieces. And it does so by breaking up what are called covalent molecular bonds. So it breaks up the bonds that hold proteins together, the polypeptide bonds, and what holds sugars together, what holds fats together. So all of your body is made up of basically 4 types of molecules: sugar, fat, protein, and nucleic acids. Okay? And then of course there's also vitamins and minerals, but all the organic matter, like disc material, all of this carbon-based matter, what makes us carbon-based life forms as humans, is proteins, fats, sugars, and nucleic acids. So this laser basically delivers high energy to the bonds that hold molecules, atoms together, and breaks those bonds. So it works at a molecular level, almost an atomic level. The process is called vaporization. You know, it's where you deliver so much energy to an organic life form or life or entity that it vaporizes. It literally breaks apart. There's also some cooking, but the cooking is part of the vaporization. Now the other thing this laser does that's unique, and I've talked about it before, is this laser actually delivers us like a pressure wave through the water that blasts things as well. So there's a mechanical effect where it shakes things up and moves like pieces of disc herniation out, but it also has a chemical effect on the bonds where it breaks the bonds up between atoms and molecules. Great question. Somebody the other day, I was talking about the Duke laser disc repair on Facebook, and one of the trolls on one of the sites, I was trying to help people understand what we do, and I was talking about the laser surgery, and this guy says, "Oh, you're just a knife-happy doctor." And I said, "It's a laser, not a knife." Right? That's one of the things I get to say as a laser endoscopic surgeon. I don't have to take the knife criticisms. I mean, sure, I use a knife to make a little cut on the skin, but the surgery is done with the laser. You can see what the laser does. I'm a laser-happy surgeon, right? Not a knife-happy surgeon. So get it right, please. Great questions, though. I'm really happy to see Chet and Sunny, you know, taking the broadcast and picking up where Diego left off. Keep the questions coming. This is a live stream for a reason. We want to answer your questions in real time.
Doc, got another question from Facebook from Alan.
Okay.
Hi, you mentioned annual tears. I have them on MRI on L3, 4, 5, 6, but no pain, but stiffness in lower back, but weakness in left foot and twitching in both lower legs. Could this be from these tears?
Yeah, so I need you to somewhat repeat because the volume somehow has gotten lower. So if you could boost it another 10 or 20% so I can hear you, and then slow down just a little bit so I can catch everything. But you said something about they have annular tears, they don't have any pain in their back, but they have weakness in their legs, I think.
Yes, stiffness in lower back, weakness in left foot, and twitching in both lower legs. Can these be from the tears?
Okay, so the tears can cause, the annular tears are the first step in a herniation. So annular tears by themselves don't do anything. They don't cause any leg symptoms. They don't cause any back pain. There has to be a herniation, and a disc bulge is a herniation. So right there you can have some back pain. Now, as far as affecting the legs, can an annular tear with a disc bulge cause leg symptoms? The answer is yes, they can. Can they cause twitching of the legs? I'm not really sure what you mean by twitching, but if it's just muscle twitches, if it's true muscle twitches, it's extremely unlikely to do that. If it's spasms of discomfort, then yes, they can do that. But if it's just muscle twitches, it could be like another cause. You need to see a neurologist. That's what I would recommend. See a neurologist. Now, if you want to know if those bulging discs could be causing, leg symptoms from pinched nerves, then send me your MRI and I'll look at it. But I need to look at the MRI to be able to tell you that. I cannot do it based on a radiology report. The radiologists don't have enough information. I need to see it with my own eyes. So if you'd like my opinion on whether or not the this is all fat right here, by the way. Okay, that's called epidural fat, and it's normal. It's supposed to be there. It looks really healthy, really good, but it's getting in the way of me doing my job, so I'm going to have to blast it. Okay, I'm almost done treating this herniation. So to answer, if you want my opinion on whether or not your disc bulges could be causing your muscle twitches or spasms in your legs, upload your MRI. I'll be happy to look at it. We do this for free. We don't charge. At mri.dukespine.com. Will you put that link in there so they could click on it and upload their MRI? But in general, a disc bulge that doesn't make contact with the nerve root and is not causing any pain it would be unlikely to be causing muscle spasms in your legs. Very unlikely. But I can give you a more accurate answer for your specific case if you upload your MRI. Just to say, Duke Spine Institute, we do free MRI reviews. We don't charge. Generally, we do an MRI review and then we do a quick video conference on Zoom. We do those every week. We do it to help people who are suffering around the world that don't have access to a doctor who can figure out what's wrong with them. And rather than making them fly all the way to Florida to see me, we do it digitally to help people. And again, currently there's no charge for it. We're in 2022 and it's January 6th. Great question, by the way. All right, we're almost done with this disc. I've pretty much eliminated all the nucleus that's herniated. I'm just going lateral here. I want to make sure I get any more lateral herniation. I don't want to leave any of this stuff. It can actually push on the nerve root as it goes down the leg, exiting the spine. So I want to make sure I get as much of this herniation as I can.
Doc, got a question
Yes.
from YouTube from Roger. How do you know when to stop when you have taken enough material out?
Yeah, great question. So the way I know to stop is I can see side to side. Those are the end plates. Those are basically the bones that are on the sides of the disc. And I look here at 12 o'clock where the laser fiber is, and that's the epidural space. That's where the nerves are. They're right behind that fat. And so I know that I've kind of reached the outer part of the disc and I've removed as much of this nuclear material as I can. So that's when I know when to stop. See the scar tissue there, the little waves? They look like little waves like on the ocean, like white caps. That's just scar tissue. That's from inflammation. So I've gotten rid of pretty much everything I can. And that always seems to be enough. See that little area right over there, that little beige area? That's the end plate. That's the bone. So I know I've gone from, bone to bone, and this is a giant tear. I knew that based on the discogram. I knew it was going to be floor to ceiling, basically. Great questions, great questions. All right, I'll try to show you the nerve root right now. There's an exiting nerve root. That's it right there. You see the white thing? That is the nerve root right there. Okay? And that one is the, what disc are we at? L4-5? So that would be the left L4 nerve root right there. The herniation was just underneath it. And medially, there's going to be another nerve root just behind that fat. That would be the L5 nerve root. You can see the little blood vessels there and some fat cells. You can almost make out the individual fat cells. Little spheres, okay? So yeah, I'm very happy with this. It's a good result. We're done on this disc. So now I'm going to suck the irrigation out of the tube, and we're going to use a little antiseptic called betadine. And betadine is wonderful stuff. We use it topically. You never inject it into the vein or anything. It's a topical antibiotic. It kills pretty much fungus, bacteria, viruses, anything that could have gotten in there. We didn't expect anything. This is a sterile procedure, but you never know. I mean, sometimes you can get something in there inadvertently. So it's always good to irrigate and clean things out to make sure that you've gotten any kind of infectious agent if it did get in, which we don't expect it to, but I want to irrigate out as much of the iodine solution as I can. That's great. And now we're pretty much done. I'll put a little bit of medicine in there to reduce any inflammation I may have caused from the surgery. And we're going to take this tube out. And I'm going to show you just a minute here if you want to take a look. The whole disc repair is done through a 7mm tube. Everything is FDA approved. I'm going to apply a little bit of pressure to the side of the spine in case there's any venous bleeding. And notice I have my other needle in place. So we've already accessed both discs, herniations through the tear. I did that at the beginning. And let's go lateral. So once I get 2 minutes of pressure on the muscles to minimize any bleeding, then I'm going to move on to the next disc. You can see the spinal needle is already there. And that's the L3-4 disc that we'll be fixing next.
We need an X-ray on that, please.
So I'm going to start by putting the guide wire down and shot. Okay, so somehow our needle came out. That's not good. We're going to have to shot. We're going to have to redo it. Interesting. So all that movement, I must have pulled it out. So we'll just reposition that in a moment using our X-ray. All right, do we have another question? We live stream our surgeries because we have nothing to hide. We want the public to see what it's like in the operating room when doing surgery. And, you know, we want them to see what state-of-the-art spine surgery looks like. People have, I think, misconceptions about it. And I want to eliminate those misconceptions. Let's get an AP.
Doc, got a question from
Yes.
Graham again from Facebook. YouTube.
Sure.
Does it work on degenerative disc disease?
Does this surgery work on degenerative disc disease? Is that the question?
Yes.
Yes, it does. 100%. It does. The Duke laser disc repair works on herniated discs, bulging discs, degenerated discs, and I could keep going. There's a lot of adjectives, but they all basically are the same thing, which is slip discs and ruptured disc and extruded disc and migrated discs. There's so many names for a disc problem. The reality is it's all the same thing. It's a tear in the annulus where the nuclear material has now come out and is shot and is now causing pain in the back and down the leg. All right, shot. Let me get an AP. I think I'm hitting the top of the end plate because it feels firm. Yeah, that's what I'm doing. Back to a lateral. So I'm repositioning this needle and we're almost have it where we need it. Once I do, we're going to put the guide wire down. We're going to then put the dilator down over the guide wire and we're going to finish our last disc. Shot. Once again, I've gone through the tear that's already there within the annulus into the disc. So this is a wonderful technique because we're not damaging anything in this patient with the surgery except for her skin. We've made a 7mm cut. That is literally the only damage we're doing. Once we get past the cut, we have a dilator that spreads the tissues. Let me show you. This is the dilator. Okay, so the end of it is hollow. It's got a little hole right there that goes down the guide wire, and it literally spreads open the tissues. So it doesn't cut anything. It just separates tissues. So it's a very gentle procedure. I didn't develop this technique right here. This is all developed by other surgeons and scientists ahead of me. This is an established treatment going transforaminal endoscopic, but what's unique about my surgery is the annular debridement, annular treatment. In other words, the focus on the annular tear is what separates the Duke laser disc repair from all other spine surgeries. No one else pays attention to the annular tear. All the other surgeons focus on the herniated disc, the piece of disc material that's hitting on the nerve. And once they get that out, they're done. But they've left the undebrided annular tear there, and so of course the patient's still going to have back pain, still going to have reherniation possible, because the tear will never heal itself until you clean it out. All right, guide wires out. Shot. Looking good. Through the tear. And again, the disc is pushing me out again. Shot. The reason is there's so much pressure inside the disc. Shot. All right, we are at 3-4. Everyone agree? This is our second disc and our last disc. So once we're done here, we'll be done. Let's see if it's pushed me out again. It actually pushed the needle out. That was amazing. I've never seen that happen. Shot. It's actually pushing the dilator out. There's so much inflammatory pressure inside this disc that it's literally pushing everything out. It's kind of like a swollen knee. Shot. So I have to be very careful that it doesn't push it out while I'm doing this. Otherwise, I'll be going into a place that I don't know where I'm going. You always have to make sure you maintain control of the pathway into the disc. If you lose your connection from the outside world to the tear and the disc herniation, you have to start over. You can't just go blindly. Otherwise, you can do a lot of damage to the patient. All right, so again, 7mm incision. We're going to go in and repair L3-4, left side. I already feel like it's pushed the tube out. It has. Amazing. Look at that. Well, I feel it's still in the disc, so let's go take a look. Let's hold this here so it doesn't go out any further. That's amazing, huh? A lot of pressure. Okay. Well, that's definitely disc material, stained blue. The dye we use only stains disc material, and it's just very edematous. Edematous means it has edema. Edema means swelling. Laser, I'll hold this. Hold this. Thank you, Luis. All right, keep the questions coming. I really appreciate them. This is our second disc we're fixing, and this is the left L3-4.
Doc, got a question from Graham again from YouTube.
Sure.
Going back on the first question, can a hardware shift on extensions and flexion 2 weeks post-surgery?
Can a hardware shift on flexion and extension 2 weeks post-surgery? I mean, it shouldn't. It depends on what kind of hardware. So if you have an artificial disc, it will shift on flexion extension. If you have a fusion, it should not shift. Wipe it. A fusion should not shift. So it depends on the kind of hardware you have, to be honest with you. I would talk to your surgeon. Your surgeon knows what they put in you, and they would know if it's supposed to shift. Okay? But generally, if it's a fusion, it should not shift. But I can tell you this, and be careful, because when you get an x-ray, every time you go get an x-ray, the x-ray technician takes a picture from a different angle. Okay? So it's never going to be exactly the same. So it may look like the hardware has shifted when it hasn't. So it really takes a critical eye, like a surgeon's eye, or a really good radiologist's eye, or even a good tech's eye, to really know whether or not the hardware has shifted. Okay? So don't assume it has, because there's other factors involved. like the angle that they're taking the picture at. It can literally make the hardware look like it's shifted. That's usually the reason. And again, we offer a free service. If you're unable to do that, you just upload your images on our website, mri.dukespine.com, and I'll be happy to look at your images and answer questions for you myself. Okay? Let me see. Hold it here. All right, once again, big tear right here. To me, this looks like it matches the age of her accident. That's when all of her symptoms started. She didn't have any problems before the accident. It's all new. She's traveled from Jacksonville, Florida to us to have this procedure done. She found us on the internet. She recognized that this surgery is revolutionary, and she's seen the results, and she was very happy with the patient's results that we've had. And so she came here with her mother to get the surgery done. Her mother is keeping her company, taking care of her afterwards. But this is an outpatient procedure, and there's no hospitalization. Patients can walk out of here basically right after they're done, usually an hour later. Oh, still stuck. Look at that. Here, wipe. All right, we'll be done in less than 10 minutes, doctor. Great questions from our audience today, and I really appreciate it. I'm glad we have an audience. We're here to answer questions, to provide information, and to dispel myths. The most important message that we have to people is that your back and neck pain can be cured with the right treatment. And the right treatment is here at Duke Spine. Unfortunately, every spine surgeon and doctor treats people's pain differently. And most of the treatments we have available today don't cure pain, like epidurals, medial branch block, rhizotomy, injections. They just don't cure the pain. Spinal cord stimulators, morphine pumps, dilaudid pumps. These things don't cure pain. There's only a couple of treatments available in the world that actually do cure the pain. For example, surgery on the disc is necessary to get rid of disc pain. That's what we're doing right here. Surgery on the disc to get rid of disc pain. Good fusion would also get rid of this pain if it's done properly. A good artificial disc surgery can get rid of this pain if it's done properly. But why have a fusion or artificial disc surgery if you can have this endoscopic laser surgery? There's no reason to. Let me have it. Thank you, Luis. So the blue line, if you haven't caught up yet, that's the laser. And you can see how easily it vaporizes the tissue. I'm protecting the nerves around the retractor because that retractor is made out of steel. So you can't really hit the nerves as long as the retractor is there, protecting them. Of course, you have to know where the nerves are. That's why it helps to be a surgeon. And you shouldn't be doing this stuff if you're not a surgeon. By the way, anybody interested, we've got cold iced coffee in the refrigerator. If you're an iced coffee person, in the break room. Yeah, you're welcome. And as they say, it's teamwork that makes the dream work, right? So let's have a discussion since nobody's asking questions. I want everyone's opinion. Who's the greatest basketball player of all time? Okay? There's a big debate going on right now. I don't get political, but I don't think this is political. And there's no questions about the spine. Luis?
I think it's Jordan for me.
Jordan.
Yeah.
All right. Your opinion, doctor? Any basketball player of all time. You're saying Kareem Abdul-Jabbar. That's a good one. Kareem is pretty amazing. Huh? Who are you saying? Oh, Brazilian basketball player? Nice. What's his name? Ronald Tebow? All right. Anybody else have any differing opinions? Jordan? You say Jordan? Jordan for Jordan. All right. Jordan, our X-ray tech, is saying Michael Jordan. But you only get one vote. You can't have two. You're saying Jordan. All right. So 3 votes for Michael Jordan. Nobody's mentioned LeBron James. Why? All right. Who else do we have in this room? Patience asleep. We can't ask her. Kobe.
Curry, Stephen Curry is good.
All right. I got to say, I was a basketball player for many years and played varsity in high school. Was never the MVP, but still a very good player. Literally played most of my life. I'm going to have to say Michael Jordan, okay? And I love Magic Johnson, all right? I'm very close to saying Magic Johnson because Magic is one of those very special players that, you know, Jordan had a bit of flair, right? Johnson never had flair. I mean, he didn't show off. That's what I'm saying. He was very humble and just played great basketball. So, I don't know. I feel like I have to say Magic Johnson just so we get the name out there, you know? But Kareem was amazing too. Probably the best center of all time, for sure. Larry Bird, amazing, amazing, amazing player. Amazing. And I really enjoy those days when the Lakers used to play against the Chicago Bulls. Those are the greatest. I mean Celtics. Sorry. Celtics and then the Chicago Bulls, of course. Those old days back in the 80s. Of course, I was in Los Angeles at the time, so I had to be an LA fan. But who just came in?
Oh, that's Flynn.
Flynn, you didn't get to vote. Greatest basketball player of all time. So we got how many votes for Jordan? Really, like 3.5. If you count mine, then, you know, I'm giving half a vote. I got to give the other half to Magic Johnson. Almost done. This is taking a lot of energy, just a lot of scar tissue. Just about done. There's sort of the end of the tear right there. We'll clean that up and we'll be done with this disc. Hope we haven't offended anybody out there, but we're just polling everybody in the operating room. Who's the greatest basketball player of all time? If you're in the audience watching, you're welcome to cast your vote as well.
Got a question, Doc,
All right, we'll take the question.
from YouTube. A doctor's asking, is there a risk of the pass point beyond the all?
Okay, so I could not really hear exactly what you said.
Okay, I'll repeat it again. Is there a risk of the stealth pass pointing beyond the all? That's how he wrote it.
Oh, is there a risk of the laser pointing beyond the hole?
He says stealth.
I'm not sure what the stealth is, but this laser here can only release energy at the tip. So there's really minimal risk. Like, see, if I shoot it from here, it doesn't do anything. It doesn't do anything to the disc. So you got to be like right on the tissue to do anything. So it's very safe. There's really no risk of it going past. Lasers are some of the most misunderstood tools in medicine. There's a lot of people who come to say things about the laser, bad things, like, oh, it doesn't work, it's not necessary, it's a gimmick. But I can tell you from using the laser for 20 years, it's incredible what it does, and there's no other tool in the world that is anything like it. It's the best. So that said, I started using lasers when I was in neurosurgery training at UF in Gainesville with Dr. David Pincus. We were using them on pediatric spine surgery, and we were using lasers to do basically untethering of the spinal cord, because we needed tools that were very precise, so we use lasers. The reason why a lot of surgeons foo-foo lasers is they don't know how to use them. They've never been trained on them, and they don't have access to them. So it's kind of like, you know, foo-fooing the electric cars if you don't have an electric car, you know? So the reality is they're expensive to buy, but so is everything in spine surgery. So there's really no excuse, but you also don't need a laser unless you can see it, what it's doing, and that's why endoscopic surgery is so important. We're using endoscopic surgery to see the laser. For example, if I didn't have a microscope or endoscope to see what the laser's doing, which most surgeons don't have a microscope or endoscope, they just use their eyes. If you use your eyes, you can't see what the laser does. You can't use the laser. It's not possible. So by being able to see what it does on an endoscopic or microscopic level, I'm able to use it properly. So all these surgeons that foo-foo the laser, they're not endoscopic, microscopic surgeons. They're just regular spine surgeons doing spine surgery like it was done 100 years ago. And they're not really progressive. They're not moving forward with the changes in technology that make it better. There's a lot of new technology in spine, but most of it's junk. Doesn't really help patients have better outcomes. On the other hand, this laser and endoscope, this technology we're using today is a massive advance because it keeps people from having fusions. And the results are amazing. Fast recovery, excellent results. Right, Luis? All right, great question. Just about done. 2 more minutes, I think, and we'll be done. There's just a big tear here, bigger than I thought. Some bone spur too. Just about done. There's the epidural space. So I'm just going to clean this rest of this tear up. I don't see any more nuclear material, so we're good. This will all heal beautifully over the next 6 months to 9 months. Just had to get rid of the blue stuff. Get the pressure off the nerves. Just about done. We finished 2 discs. I think this patient's going to recognize that her pain is gone in her back. You saw how bad her pain was on the discogram. She had 10 out of 10 pain and 12 out of 10 pain. So the discs were really painful for her. Plus she had that leg pain. She could barely walk because her left leg, she had those nerves getting pinched. And now we've unpinched the nerves. And we've cleaned up the tear to get rid of her back pain. She's going to feel like a new woman. I'm very happy for her. Any other questions? Any other questions?
Yes, got one from Patrick on Facebook. When removing the herniated disc with the laser, does it stop hibernation?
When I remove the herniated disc with the laser, does it stop the herniation? So the patient can re-herniate, just like with any spine surgery. They can re-herniate, but with this spine surgery, the chance of re-herniation is far less. Our re-herniation rates are 1%. That means 1 in 100 patients will re-herniate. And I can tell you almost 100% of the time when that happens, it's because they didn't follow our instructions after surgery in terms of restricting their activities. So people feel so good after the surgery that they go out and just do whatever they want to do. And you cannot do bending for 6 weeks to 3 months, depending on how many discs and how bad the discs were damaged. And you cannot do heavy carrying, lifting heavy things. All right, that's pretty much done. The nerve root's right up there. I'm going to get a little bit more of that disc right here. 1 minute left. We're just about done. Just got to get this little bit of disc here. I don't know if I answered the question, Patrick. I hope I did. Hope that makes sense. So any surgery, whether it's laminectomy, microdiscectomy, even fusion, even artificial disc, all of them allow for reherniations. Even Duke laser disc repair, what you're watching now. The risk of reherniation is much lower with this surgery than any other surgery. And the reason for that is because I'm not removing any bone. I'm not removing any ligaments from the spine. So this is all natural without removing any of the stabilizing structures. When you do a laminectomy, you're removing bones and ligaments. When you do a microdiscectomy, you're removing bones and ligaments. When you do ultrasonic technology, like some doctors promote, you're removing the bones. And that's bad for the spine. It weakens the spine, destabilizes the spine. So the chance of reherniating goes up with instability.
Doc, got a question
Yeah,
from Facebook from Rick.
sure.
He says he's claustrophobic for an MRI tunnel. Can a CT scan be used for his back issues?
He's claustrophobic for an MRI. Can a CT scan be used? The answer is you can use a CT, but it's not nearly as good. There are MRIs now that you can do the whole MRI in literally 5 minutes. It would be better to get the MRI done. You just have to find a good MRI. The older MRIs, you know, it's 30 minutes to 40 minutes to get that MRI done. The newer ones, it's literally 5 to 10 minutes. So the amount of time in the MRI scanner has dramatically decreased. I would recommend trying the MRI, whatever you can do. It's going to give you a much better idea of what's going on in your back or neck. Okay? So will a CT scan work? A lot of times a CT will be okay, but truly an MRI is your very best tool. So whatever you can do, try to, you know, lay there if you can and maybe take some Valium and just do your best to get an MRI. All right, we're pretty much done. I just want to grab this last piece and then we're coming out. If you have questions, I'll answer them for you. Just type them up and I'll do my best to answer them in the next 5 minutes. Sonny, can you run a video? Can you run the Duke laser disc repair lumbar video?
Yes.
So if you guys could run that right now for our audience to watch, they can see what I just did. And as soon as that's over, run the comparison video between fusion and Duke laser disc repair. And I'll be there shortly to answer questions. I'm just going to wrap this up. All right, I think we're done.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. the laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Duke laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Duke laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Duke laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Duke laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Duke laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Duke laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Duke laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Duke laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Duke laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Duke laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Duke laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Duke laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Duke laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Duke laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Duke laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Duke laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Duke laser disc repair, there is no damage to the muscles. The Duke laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Duke laser disc repair. Spinal fusions have a high risk for infection. The Duke laser disc repair has a very low risk for infection. In the 7 years the Duke laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Duke laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Duke laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Duke laser disc repair. In fact, most Duke laser disc repair patients experience improved mobility after the surgery. The Duke laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Duke Spine Institute. With the highest published success rate of 95%, the Duke laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs. Duke laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Duke laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Duke laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Duke laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Duke laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Duke laser disc repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Duke laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Duke laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Duke laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-Strips, and a Band-Aid. Total time for the Duke laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Duke laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Duke laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Duke laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Duke laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Duke laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Duke laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Duke laser disc repair, there is no damage to the muscles. The Duke laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Duke laser disc repair. Spinal fusions have a high risk for infection. The Duke laser disc repair has a very low risk for infection. In the 7 years the Duke laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Duke laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Duke laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Duke laser disc repair. In fact, most Duke laser disc repair patients experience improved mobility after the surgery. The Duke laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Duke Spine Institute. With the highest published success rate of 95%, the Duke laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.